Okay, good afternoon, everyone. Welcome to another episode of our weekly seminar series. Today's speaker, who Michaela will be formally introducing, is a special guest, the Dean of the relatively new School of Health at Georgetown University. And I'll let Michaela tell you a little bit about his background. I just want to mention that the Health in the Public Interest MS program is a one-year MS at Georgetown University. It's now in, I think it's eighth cohort, perhaps. I co-direct the program with Dr. Fu Berman, who is also in attendance, and so we welcome all of you. The program seminar series is run the same way every week. We have a student moderator who will be introducing Professor King. He will speak for about 45 minutes. And unless he asks for participation, we're going to have everybody muted to begin with. And once we get to the end of his talk, Michaela will take over again and invite questions, first from the students and then from the broader audience. I'm happy to see a pretty robust attendance today, and I'll turn everything over to Mickey. So thank you, Mickey, for running the show today.
Morning. It's my pleasure to introduce Dr. Christopher King. He is a nationally recognized health system strategist, educator, and thought leader whose expertise is at the nexus of health system transformation, public health, health equity, and health professions education. As inaugural dean of Georgetown University School of Health, he works with internal and external stakeholders to establish a world-class academic destination for advancing health and well-being through innovative research, interdisciplinary education, and transformative engagement with communities. He's responsible for academic and operational leadership of the school, which is composed of 3 departments: human science, global health and health management and policy, and a growing healthcare graduate degree portfolio. Prior to his role as dean, he served as chair of the Department of Health Systems Administration, where he provided visionary leadership and oversight of the undergraduate degree in healthcare management and policy and a nationally accredited Master of Science in Health Systems Administration. As an associate professor, he teaches and contributes to scholarship on the creation of equitable systems of care within the context of national health reform goals. He works closely with public and private providers to bridge the gap between medical care and healthcare. Prior to joining Georgetown University, Christopher served as the first assistant vice president of community health for MedStar Health, a $6 billion not-for-profit healthcare system comprised of 10 hospitals in the Baltimore, Washington region. Accomplishments included planning, launching, and managing a new corporate function designed to apply more rigor and evidence in community-based planning, implementation, and evaluation. He was also responsible for developing, testing, and evaluating innovative approaches to integrate social factors in systems of care. Prior to his work with MedStar Health, Christopher served as a director for Greater Baden Medical Services, Inc., a federally qualified health center in Southern Maryland. During his 4-year tenure, he managed federal grants, oversaw support services, and secured more than $7 million in public and private grants to promote health equity and improve the health of vulnerable and underserved populations. Through volunteer work, he has spearheaded regional efforts to heighten awareness of how racism, discrimination, and implicit bias influence individual and population health. Christopher is an active member of the American College of Healthcare Executives and has been a contributor to Healthcare Executive magazine. He's conducted health disparity and health equity presentations to national audiences. And as a former senior fellow of the Health Research and Educational Trust, Christopher represents an esteemed group of national thought leaders dedicated to transforming healthcare through research and education. His national investigations on screening and barriers to care among cancer survivors by race and ethnicity were published in the American Journal of Preventive Medicine and the American Journal of Medical Quality. His thought leadership around Black lives and the triple aim has been published in the Journal of the National Medical Association. Christopher is a fellow of the American College of Healthcare Executives, and he currently serves on the DC Hospital Association Board of Directors. He's also been an advisor for the DC Department of Health State Innovation Model, Adventist Healthcare Center for Health Equity and Wellness, and the Maryland's Maryland Governor's Well Mobile Program. In 2019, he was appointed a commissioner for the District of Columbia Commission on Health Equity. In 2020, he authored Health Disparities in the Black Community, an imperative for racial equity, and most recently, his work on race, place, and structural racism in the District of Columbia was published in Health Affairs, the nation's leading peer-reviewed journal on health, healthcare, and policy. The Washington Business Journal has recognized him as one of the region's top minority business leaders. Christopher has a BS in Community Health from East Carolina University, an MS in Health Science from Towson University, and a PhD in Health Systems Administration from University of Maryland School of Public Health. He also has a wonderful golden doodle that he loves, Winston. And now, without further ado, I'm going to go ahead and turn it over to Dr. King.
Thank you, Michaela. Yes, I love my dog. I love my dog, Winston. Some of you may have seen him over here on campus. Adam, Adrian, thank you so much for this opportunity. It just brings me so much joy to be in this space with students who are pursuing this degree, as well as those who just are interested in this content. Thank you for being here today. It is my hope, it is my prayer that throughout our time together, I will say something that will inspire you, that will give you hope, that will charge you, that will serve something that will serve as a cue to action, because we have our work cut out for us. The world in which we live is in pain, and it is our moment to do some really, really good work. So thank you again for this opportunity. Let's see if my slides share. I know we did this earlier and it worked. So let's see if we are still in luck. We're good? Michaela? Okay. All right. Very good. All right. So this talk is titled From Medical Care to Healthcare: Lessons from the Field. And I am bringing to you years and years of work. As I speak to you, just know that I am reflecting the narratives of people that we've interviewed over the years who let us into their experiences in their communities and in the public health sector, right? My work has been around, how do we improve our healthcare delivery system? How do we improve our public health infrastructure to meet the needs of our most vulnerable brothers and sisters throughout the world? My work has been mostly domestic, but I am growing into the global space now. But just know that my presentation, my talk, is based on what I have learned and what we have learned, my colleagues, over the years in our interviews with people, to better understand, how do we do better? How do we create a healthcare system that works for all people? How do we modernize and improve our public health infrastructure so that when there's another pandemic, we're ready, right? This is our moment to do this work. And I titled this From Medical Care to Healthcare because I believe that we have not cracked the code on how to deliver healthcare in this country. We've cracked the code on delivering medical care, but how do we deliver healthcare? And I'll share some of my thinking about that as we go through our time together. So, of course, as an academic, I have to have some learning objectives here. And so we're going to take a moment just to unpack health equity. I know that this is probably content that some of you have mastered, but I just want to be sure that I'm level setting as we go through these slides. What's the business case for health equity? And what's the moral imperative for health equity? We'll also look at some opportunities to shift our healthcare delivery sector from one that is biomedically postured to one that is biopsychosocially postured. How are we training folks, right? Historically, we have been missing the mark, and that's what I love about academia. And what we're doing now is we are critiquing the status quo and exploring new opportunities to train health professionals to meet patients where they are, and to deliver or develop interventions that are going to make sustainable change in communities. And then what are some of the unconventional competencies that we need to see in healthcare as well as in public health so that we can close that gap in trust and build more impactful partnerships with communities? So I'm very interactive. So I would like for someone to tell me, what do you think this $4.5 trillion price tag represents? I'm looking at screen. I'm looking for a hand. Take a stab at it. Anyone? Any guesses? What does 4.5? What does this mean? I always like to start off my presentation with this price tag. No one? All right. And that's why I'm here, because my goal is to impart knowledge. So 4.5 trillion is what the United States spends on medical care annually, right? 4.5 trillion. So you're probably wondering, give me context, right? Is that a lot? Is it not? I mean, given the population that we have here, you need context. And so I like to share this slide for context. Take a look at this. Let's see. Let's go through healthcare spending. All right. And you can see on the vertical axis is percent of GDP. The horizontal axis represents years. And what you see are the healthcare spending as a percent of GDP when we're looking at other industrialized countries. And you can see that our lovely United States is pretty much off the chart, right? We're spending so much on healthcare, almost 2 times more per capita than other peer countries. Okay, so you're still wondering, are we getting what we're paying for? So let's go back to this slide. Sorry, let's go back to this slide. And so I share this with you. You can see life expectancy at birth, and that's what the vertical axis represents life expectancy. And then you can see by year, and you can see that compared to other countries, our life expectancy is among the lowest. And it's been like that consistently for decades, right? So we're spending a lot more. Life expectancy is lower. Quality of life, if you look at some metrics, is lower than other peer countries. So clearly we're doing something wrong, right? Clearly we are missing the mark. There are many, many explanations for this. I'll share some of them through as I go through this talk. I'd love to hear some of your thoughts as we wrap up. But this is again, I like to start off my presentations just with that price tag so you can see this is how much we're spending, but this is what we're getting in return. So something's not right. And so my goal and what I'm hoping today is that I will share with you some opportunities for us to focus on prevention so that we can bring down that price tag, have longer life expectancy, have a better quality of life. If we just redirect how we think about spending and how we think about, healthcare and how services are organized, delivered, and financed. So the few slides that I just shared with you really were key motivators for why we established a School of Health at Georgetown University in 2022. And how do we distinguish ourselves in the market? Georgetown is the oldest Catholic and Jesuit university in the country. We're 235 years old. We have an opportunity here. And we will never be a Johns Hopkins. We will never be George Washington has a school of public health. We will not be those schools. We will not, and we don't profess to act like that. We are Georgetown, and we are going to carve out a new identity in this space. That's what we intend to do, with a focus on justice, with a focus on making decisions that are in the best interest of the common good, with a focus on caring for the most vulnerable. And that's where our efforts are here at the school. I like to share this. You can see this behind me as well. But this is, if you ever come into our space, you'll see this image. And when the school was formed, I asked all of our faculty and students and staff a question. What's the first word that comes to mind when you think about health? And so we put those words into a spreadsheet, and that is what is captured here. And the purpose of this exercise for anyone who sees this is to be stimulated by all of the different facets of our existence that shape how we feel, whether it's physical or mental. And it's aimed to stimulate interdisciplinary practice, interdisciplinary education, recognizing that so much around us impacts our health and our well-being. So this is the mission of the school, to advance the health and well-being of people locally, nationally, and globally. And we do this through three pillars: innovative research, the delivery of interdisciplinary education, and transformative engagement with communities. We are dreamers at the School of Health. We dream of a just and equitable world where all people can achieve optimal health and well-being. So we ask ourselves questions, right? How do we cultivate a society that perceives health and well-being as core values? How do we normalize systems of care so that they are safe and equitable and resourced with the capacity to evolve to meet the biopsychosocial needs of the community or the patients that we're serving? How do we create a society or cultivate a society that recognizes our earth as our common home and we must take care of it? It's important for us as a school to challenge all disciplines, all sectors to vet their work through a health and well-being lens, because everyone has a role to play. I'll share this with you just in case you're interested in learning more about some of the work that I've been blessed to do over the past few decades with my colleagues. And I think I've created hyperlinks. Yeah, they're hyperlinks. And when you get the slides, you can just click on it and it'll take you to the actual document. So what is health equity? Why is it important? I'm going to pause here. I would love to get some engagement here. When you think of health equity, tell me, what do you think of? Very quickly. Go. You can take yourself off mute.
Equal outcomes and treatment treatment adherence.
Okay, thank you, Abrielle. Others?
Accessibility.
Accessibility. Okay. Others?
I'm going to
Affordability.
say, go ahead. Justice.
Justice. Okay, thanks, Michaela. Francis, I think you were going to say something. You're muted.
Oh, affordability.
Affordability. Okay.
Going off what Francis said, just reducing barriers to care.
Okay. Okay. And why is it important? Why are these things important? I gave you some clues earlier.
And improving quality of life and life expectancy.
Okay. Okay. All right. Let me take you through the next few slides and you'll be able to answer this without hesitation. All right. So some of you may have seen an image like this. There are different iterations of this, but basically, if you look at these, on the left-hand side, you'll see the boxes that these individuals have to stand on are the same size, the same height, right? And on the right-hand side, you can see that they are adjusted. The apples are a metaphor for opportunity, for example. And so on the left-hand side, equality means everyone's getting the exact same thing. But we know that that's not always fair because everyone didn't start off at the same place, right? And so we adjust to fix that. We adjust resources according to need. And that is what you see on the right-hand side. I've been thinking a lot about our founding values as a country, and how our founding values in a lot of ways can impede or compromise our aspirations when it comes to population health improvement and improvement of just the health of the nation. For example, if you look at our founding documents, you will see equality written in a lot of different places. You won't see equity, right? So we are in a space where we want equality. Everyone should be given this exact same thing, but that's not always fair. And so it's important for us to normalize equitable approaches, redistribute resources according to individuals' needs. And that requires a little more work. But that is the pathway that is going to be key to addressing a lot of the issues that we're experiencing in our society. So as you can see here, and many of you probably have seen this. I know that, we talked earlier about social determinants of health before this session. But you can see the factors that shape our health, right? And you can see social and economic factors, the overwhelming majority. Physical environment plays a role, clinical care, health behaviors. Now, again, clinical care represents 20%. So again, this means that if we, look at the character or the factors that shape our health over the lifetime, clinical care only represents about 20%. The rest of it comes from outside of the clinical care space, right? Where we live, learn, work, eat, and play, and the behaviors. And we know that there are a lot of correlation between social and economic factors and health behaviors. For example, there's a correlation between likelihood to smoke based on level of years of education, right? And so it's important for us, if we are trying to improve the health of a population, to redirect resources to make sure that we are addressing these factors that you see here. And if you look at other countries that are doing a much better job, they've invested in social and economic factors. And as a result, they experience, they're better when it comes to the metrics that we use to assess quality of life, and such as life expectancy and infant mortality. All right. So why do we see differences? And I always like to just be sure to articulate what is a disparity, what's the difference between disparities and inequitable conditions. Inequitable conditions are the causes of disparities, right? And so when you have two populations, let's say one on the south side of Main Street and the other on the north side of Main Street, and the folks on the south side of Main Street do not have access to the same level of opportunities as the folks on the north side, over time, we will see differences in those two populations, right? Those are inequitable conditions, right? To go back to education, housing, income. When we have one community that does not have equal opportunity to those resources, we will see differences when we compare those two populations. And those differences, my friends, they are measurable, right? They are empirical. We see them in differences by the disparity is a measurable difference in the incidence, right? The number of new cases, prevalence, new and existing cases, death rates, burden of disease. We will see that by those two different geographies. And this costs this country a lot of money. Earlier, I mentioned the 4.5 trillion, but it's estimated that disparities cost us about 320 billion a year. And if we don't get our acts together by the year 2040, we'll be up to $1 trillion. So what are the root causes of these inequitable conditions? Well, a history of unjust policies and practices. Think about redlining, think about housing discrimination, voter suppression. Implicit bias is real. There's also institutional bias that shows up in the institutions that govern our society. And of course, there's systemic racism that continues to persist. Preservation of power and privilege is a root cause of these inequitable conditions. And then just this default to traditional norms and practices. And in my work and in my teaching, I always challenge our students and our faculty to critique the status quo with an equity lens. In other words, what are we doing or saying or teaching in ways that one population feels left out? And I would argue that when we continue that and a population is left out, we are not doing our best work, right? And so it's important for us to constantly critique the status quo. So I want to talk quickly about this paradigm shift, and I'm going to just give 3 examples of why it's important for us to critique the status quo. Earlier, I mentioned that we are delivering medical care. Our healthcare delivery system is biomedically postured. It is not biopsychosocially postured. It is my opinion that when we create systems of care that are biopsychosocially postured, that is healthcare. And I'll give you an example of that shortly. How do we think about race, right? It has been interpreted historically as a biological risk factor, and we know that it is not solely a biological risk factor. We need to rethink how we conceptualize race. We need to unlearn how we've been taught to think about race. And then cultural competency. What is that? And how do we evolve from cultural competency to demonstrating cultural humility and working with patients and then working with communities? I'll give examples of each one of those just a moment. So here's a case very quickly. Mr. Jones is living with diabetes. He recently was given 2 prescriptions, and those prescriptions need to be taken with food. Mr. Jones has been taking the meds, but he is experiencing food insecurity, and he has unstable housing. After 1 week of consistently taking the prescriptions according to the instructions, he ended up in the ER with stomach ulcers. All right. We see this quite a bit. So what happened here? He's taking a medication. The medication needs to be taken with food. He has been experiencing food insecurity, and he has unstable housing, but he's been taking the prescriptions. He's been taking the medications. But now he's in the ER with stomach ulcers. This is a classic case of how we've gone wrong. Because for so long, we would just prescribe a medication to a patient and not ask about the social and environmental conditions in which that patient lives. And yet we expect that patient to follow the protocol. All right. And so no one asked Mr. Jones if he had was experiencing food insecurity. The system wasn't designed to ask those types of questions. But we're evolving now. We're seeing more and more providers ask these questions because this is a holistic approach, right? It's a holistic approach. And so we are evolving to, again, from medical care to healthcare. This is an example of healthcare when you have a provider that's asking you questions about food insecurity. So now we're starting to see more, we're seeing this embedded in the electronic health record, where the provider, there's a prompt about food insecurity. And there's 2 questions that typically we ask. Did you miss a meal within the past 30 days because of the inability to pay, or because you just didn't know where your meal was going to come from? Or do you think you will miss a meal within the next 30 days because of the inability to pay, or you just don't know where your meal is going to come from? If a patient answers affirmatively to either one of those questions, then that patient is given a prescription for food, right? A prescription for food. How about that, right? Unity Healthcare has just done this here in DC. I think I have a picture here of the great work that they're doing. Let's see. No, I don't have the picture. Oh, here it is right here. Yeah. So this was just, they just opened this a couple of months ago. And so patients at Unity who have been identified as food insecure get a prescription for food. They do not have to pay. And the food that they're getting is tailored to meet the needs of their medical condition. This, my friends, is healthcare, right? But for so very long, the way that our institutions were designed and the way that medicine has been practiced, it's just been so biomedically postured, not taking into account the environment in which a person lives, or the dearth of resources that compromise their ability to follow whatever the instruction is that they have from their doctor. And this is another example here on the right-hand side, asthma. This comes up quite a bit. You know, we've seen so many cases in this country of patients being treated for asthma, and no one ever asks them about, you know, where they live, right? And you can see on the right-hand side, this is I think her name's Katisha James. This was a story that went public a few years ago. You have a person who's paying their rent, working really hard, and they are living in conditions like this, right? And their landlords are not reinvesting in the dwelling, but you know, you know, taking people's money. And so this is why we have now medical legal partnerships to address issues like this. This is unacceptable. But for so long, in her case, you know, her and her children would go to the ER because of respiratory issues. And you see why. This is the root cause of that. But again, for so long in our healthcare system, we weren't asking these questions. And we didn't have strategic partnerships in the community to address patients' holistic needs. These are examples of why I say we must evolve from medical care to healthcare. This requires more resources. It requires different disciplines to come into this space. But I believe that this is what it's going to take to bring that price tag down from 4.5 trillion to something that's a little more realistic, more practical, more appropriate. Maria says, my doctor tells me to eat healthy. The grocery store is very far away from me. The foods I can obtain, they're not very healthy, but they are affordable. This is my local grocery store. So I think we've all heard about food deserts, and the thing I want to be sure that I leave with you about food deserts is that doesn't mean that there's no food there. It just means that high quality food is not there. And so, you know, we typically see high rates of obesity in food deserts. And I remember a politician asking me, he just could not wrap his brain around, you know, you're saying it's a food desert, but you're also saying on the next slide that we have high rates of obesity. Well, that's because the food that's being eaten is food that's not good for our bodies. And so, yeah, you're inclined to see higher rates of obesity, and you're inclined to see higher rates of people with obesity who are malnourished. Let's see here. I want to talk a little bit about sorry, I think this took me out of my slide deck. What do you see? Do you see my slides still, or you see an article?
We
What
see your slides.
you see? Okay, I'm not seeing my
Mhm.
slides. Give me 1 second. Sorry about this. All right. So we also do community health needs assessments, and we do this with MedStar, and our students go into communities to learn more about what is it that's preventing people from achieving optimal health and well-being. They do survey, they help develop the survey, they do quantitative and qualitative data collection, and we synthesize our findings and write the report. And that's what you see here. You can Google it. We just released the 2024 Community Health Needs Assessment for MedStar. And then this is some of the pieces. These are disciplines that we have left out historically when we do community health needs assessments. I share this with you just to, again, amplify the importance of being interdisciplinary in our approach to advancing health. For so long, we've done these community health needs assessments, and we've focused mainly on public health practitioners, right, to help us do this work. We have not engaged psychologists, sociologists, anthropologists, historians, arts and humanities. They all can play a role in either helping us do the assessment or telling the story based on what we find. So keep that in mind, and I'd love to come back to this during our Q&A as we think about missing persons, I call them, or missing disciplines in our efforts to advance health. We're in the District of Columbia. The university is in the District of Columbia, and it's important for us to use our agency as a university to help improve the state of health in the District of Columbia, again, with the focus on the most vulnerable. And so a couple of years ago, actually, we did some work to unpack why we see such vast disparities in the District of Columbia. We went all the way back to the year 1790, the beginning of the federal district's formation, and we captured milestones that disproportionately burden particularly Black and Brown residents of the District of Columbia to help us better understand the trends that I'm going to share with you in just a moment. We did this work because we challenged communities throughout the nation to do a historical analysis on your community. And through a historical analysis, we can really have a better sense of why things are the way they are today. And through that experience, we believe that we will inspire new practices, new policies that help us undo the damage. I encourage, if you're interested in how to do this, take a look at this publication, and you'll be able to understand why you see these trends I'm sharing with you right now. This is the District of Columbia. The District of Columbia is made up of 8 wards, right? And so we looked at 2 metrics that we rely on to give us a sense of the health of a community, how healthy a community is. We looked at infant mortality and we looked at life expectancy. And we looked at those metrics by place, by demographic trends. That's what you see here, right? So let me just give you some context. Ward 7 and Ward 8 are down here, right? 92% of the residents in Ward 7 and Ward 8 are Black or African American, right? And the further west we go, things change, right? So Ward 3, predominantly white community. And you see that the metrics, life expectancy is higher here, and infant mortality rates are extremely low in Ward 3. We have the opposite effect in Ward 7 and Ward 8. Now, Ward 7 and Ward 8 down here, when we did this analysis 3 years ago, there were only 3 full-service grocery stores, right? Ward 7 and Ward 8. That's about 180,000 people. So there's about 160,000, excuse me, residents in Ward 7 and Ward 8. In Ward 3, there's 80,000 residents. So you had 3 full-service grocery stores to accommodate the needs of 160,000 residents. In Ward 3, 80,000 residents, 16 full-service grocery stores. Right? So this is just one example of an inequitable condition that helps us understand why we can overlay this graph with health indicators. We can look at chronic disease, we can look at physical fitness, you can take just about any metric and you can surmise that they're going to be worse in these communities, just because of what I just shared with you. And so we can't continue to rely on the healthcare sector to fix this. Every sector, every discipline has a role to play in addressing these types of inequitable conditions. I also don't want to leave you thinking that Ward 7 and Ward 8 are just communities that are just, the worst of the worst. There are assets in every community. In every community that has been historically marginalized, in every community that has been underfunded historically, there are gems in those communities. There are assets, there are intellectual assets, there are geographical assets in those communities that make them very, very special. It is our responsibility to identify those assets, co-design, co-create, do whatever we can, given the resources that we have, to improve the conditions to stimulate or inspire efforts to improve the conditions so everyone has a fair shot. So quickly, I want to just talk about race and how we'll need to unlearn how we think about race and how we talk about it. I share this with you just for a point of reference. When you think about the timeline, it's 2024. And you can see here for 246 years, slavery was institutionalized in this country, segregation institutionalized in this country. I argue that we're not in the green zone. This is an image that you can pull up, Google it, it comes up. It's one of the most cited images. We're going to make some changes to this because I don't think that we're in the green zone. Just look at what's happening in the world. I think about voter suppression. I think about George Floyd. Like we're just not in the green zone. But I share this with you just to remind us that it took years. This has been happening for a long, long time. And these issues, these inequitable conditions aren't just going to be fixed overnight. It is incumbent upon us to recognize when inequities exist, when there's injustice, and to do something about it. And if we are all on the same page, and if we all stand bold and united to address inequitable conditions, we'll get closer and closer to that green zone. So I want to just go to because this is work that we see even today. We'll see biological fallacies and how patients the care that patients are receiving in medical care settings. So historically speaking, Black folks it was institutionalized that there's a genetical difference, that there's we have thicker skin or have a higher pain tolerance or predisposed to violence. And these were belief systems that were institutionalized in America's healthcare delivery system. They continue to show up today, right? This study was done in 2016 where they asked medical students about these biological fallacies. And again, this was 2016, and these were the fallacies, and you can see the number of folks who actually thought that they were true. The most common, Black people's blood coagulates more quickly than whites. Black skin is thicker than whites, right? So we ask the question, why is that, right? Did someone stand in front of a group of students and say that? Probably not, but it's institutionalized in case studies and the way that race has been, conceptualized when it comes to treating patients. And that's why I say we have our work cut out for us, because race is a social construct. If we really want to get to the root, we look at two things. We can look at ancestry, and we can look at the environment, right? I look forward to a day when and this is going to be more of one of my provocative statements, where we no longer will talk about race, because it is a social construct that is rooted in the worst of our humanity, right? Instead, culture, ethnicity, ancestry, environment are conversations that we need to have. We're trying to address these issues in a much more meaningful way. Even, just a few years ago, well, this was 2020, right? When COVID was doing its thing and ravaging our lives. This study was published in JAMA. And what the authors were saying was that Black people were more likely to become infected with COVID because of a difference in gene expression in their nasal epithelia, omitting the fact that the gene in question is upregulated by poor air quality, which has been linked to residential segregation and environmental racism. So again, once this was published, JAMA I think they're still on their apology tour, but this just goes to show you that even today, there's this belief system that, people of different races are genetically different, right? And again, it's important for us when we see that to call it out, because it continues to perpetuate problems and distrust and things that we're trying to address in our efforts to improve health. Okay, so I want to close out by just referencing the importance of evolving from cultural competency to cultural humility. Let's see. I'm looking at CJ. What do you see? Do you see anything? I'm
It's
so
just
sorry.
blank.
It's
It's
just
just
blank.
blank.
Okay.
Yeah.
Okay. All right. Okay. Okay. All right. So let's go to this last slide here. Cultural competency and humility. All right. So we have been for so long focused on cultural competency, and I would argue that we will never know everything about every culture. And to think that we can do that is, I believe, flawed thinking. But one thing that we can do is demonstrate humility. And that's recognizing that each person that we encounter has a unique lived experience. And you can't look at one person and make assumptions, right? And so I like to tell the story of Dr. Cameron, a doctor that I had 3 years ago when I changed insurance providers. It was my very first visit with Dr. Cameron. She comes into the exam room. I'm expecting her to do her thing, take my vitals and all that. She sat on the stool right across from me, and she asked me questions. She said, what keeps you up? What kind of work do you do? What brings you joy? What keeps you up at night? Tell me about your family. She was asking me a lot of questions that I didn't expect for a primary care visit. And I remember asking her, I said, Dr. Cameron, this is a primary care visit, not a wellness checkup, right? She said, no, this is a primary care visit. And she said, you're a new patient. And this is this is what I do for all my new patients. I do this because the relationship between the patient and the doctor is a very intimate one. I do not touch any of my new patients until we are both comfortable. What she was demonstrating was humility. She came into the exam room, her first time ever laying eyes on me, and she wanted to know who I am. She could have just written me off as another Black guy, right? That she's seeing. But she wanted to know who I was. She wanted to be sure that her biases did not come into play in how she interacts with me. And she did a damn good job. I continue to see Dr. Cameron. And I am comfortable with her, and I feel comfortable disclosing parts of my life with her that I think is important for her to know in her efforts to deliver the best care for me. So this is an example of how we must engage not only with patients, for those who are providers. If we're a public health practitioner, we're going into a community. If we're a policymaker going into a community, we must go into spaces with a curiosity to learn and to meet people where they are and not impose our own biases and mental models on individuals. The patients that we have interviewed over the years have said that that is where we have dropped the ball. We have went into communities, we have engaged with patients, applying our own mental models, our own biases and assumptions. And when we do that, and if we continue to do that, we continue to create this gap where populations just don't feel comfortable with us. And so I want to stop. I'm looking forward to the conversation we're going to have, but I just want to stop with just reminding us of the importance of humility and all the work that we're doing in our quest to improve the health of the country, the health of the world, and to challenge the status quo, and to know that this work is bigger than us, and the world is in need. So I'm going to stop, Sean. I'm going to stop because I'm looking at time. There's a lot of content I did not cover, and perhaps we can capture some of that through the Q&A. I'll keep my slides queued up just in case I need to reference one of the slides that either I covered or did not cover. So I'll turn it over to our moderator. I think we have, about 20 minutes?
Yes, thank you so much, Dr. King, for taking the time out to talk to us and for such an insightful presentation. We're going to start the Q&A section of our seminar. We're going to start with students. You can raise your hand, put your comments in the chat. But if any students have any questions, we'll start with the students. I see Katie has her hand up. Go ahead, Katie.
Hi, Katie.
So, hi. I was wondering, so the US is one of the, I think, very few developed nations that don't recognize healthcare as a human right, which I think disincentivizes us to focus on prevention, because we just don't see healthcare as being necessary. So I was wondering like what your thoughts are on kind of shifting that understanding and how we can speak with policymakers to kind of give them an overall understanding and kind of incentivize them to think about
Yeah.
healthcare, but prevention.
Yeah, I appreciate that. I think there's when we train our students, we train them on the importance of flexing the conversation based on who they're speaking to, right? Some people will if you come at them with this is a moral imperative, that's all they need to hear, right? But there's other populations of folks that want to see, well, if I do this, how's it going to impact the bottom line, right? And so it's important for us to make sure we have these very diverse competencies to change our script based on the audience that we are speaking to, right? So if I'm trying to get my healthcare system to invest in equity or do things that's going to improve outcomes for a community that's been historically marginalized, it's important for me to be able to help them understand how's it going to impact our bottom line as an organization, how's it going to impact how we are viewed by the community, right? So whatever it is that whoever it is that you're speaking to, it's important to flex your conversation or your script based on the audience. The other thing I wanna share is the importance of engaging non-traditional players in telling the story. And so we are doing work with performing arts and efforts to humanize the data through the arts, right? And so, through storytelling, through performances, you take these narratives and create ways that expose them to people with a focus on our common thread, which is our humanity. I believe that is another approach that we can take. But think about the non-traditional actors and engaging those individuals to help us create the compelling case for health care as a human right. Thank you for that question.
Okay, Callie.
Hi, thank you for speaking with us today.
Thank
Can
you.
you hear me all right? I'm having some issues with my headphones.
It's a little muffled, but let's see. Keep speaking. Let's see.
Okay. Well, my question was like with your example of your doctor who obviously, was a great example of all the things that you spoke on in this presentation. How can we realistically get, colleges and universities and hospitals to all like be on board with promoting this type of care when there's so many?
Yeah. I think that one, we need to, it goes into training and development. So I think we're starting now with you all and the work we're doing at the undergraduate level to train health professionals in a very different kind of way. The other thing about Dr. Cameron, keep in mind, I told you she sat down with me and she had a conversation with me. We talked for about 30 minutes. I know how the healthcare system works, right? I asked her, I said, Dr. Cameron, you're going to get in trouble because you spent way too much time with me. You're not going to hit your quota for the day. Because she's incentivized because they're getting paid based on volume. And again, patients have told us, we feel like we're just a person being pushed through a system. The system does not see us as individuals. So Dr. Cameron, when I asked her the question about, you're really going above and beyond here, she said, that's okay. She said, because my metric is that the patient population I'm caring for is doing better over time. And I know this very first conversation that I'm having with you is key to making that happen. And I do it with everybody. And so how do we create a system that incentivizes providers to perform the way that Dr. Cameron performs with new patients? Training is key. Finding new ways to tell the story about why this is important is key. Sharing best practices, what's happening in countries outside of the United States, maybe another approach. I think it's going to take a mixed bag, but I'm proud that we're, training students in a very, very different kind of way at Georgetown. Because I believe that if we can focus on the most vulnerable, if we can improve the conditions of the most vulnerable members of our society, the most vulnerable communities, that will have a ripple effect and everyone will do better, all of us. And so, we just have to come at it at different angles. Again, like I was saying earlier, modify our script so that we can resonate with different audiences based on what it is that they're incentivized by.
Okay, I do have a question in the chat from Jackson. It says, I remember you mentioning about partnerships with EHRs to collect socially and culturally accurate patient data. My question is, how do we exactly push private industry and health tech industries like EHR companies to care about social and cultural factors of health? It seems like it isn't brought forth enough in the thoughts of these companies.
I love that question. Thank you, Jackson. Love the name too, by the way. Wow. So yes, you're absolutely right. We are starting to see more and more of this, though. These questions being embedded in the electronic health record. Now, I'll tell you what physicians have told us. They've said, okay, so you're asking me to ask my patient about housing or food. What if I don't have an answer? Right? I'm in a dilemma here, and I don't want to be in that dilemma. If you can provide me with the resources or referral mechanisms for my patient, I'm happy to answer these questions. So that's been the provider dilemma. The other issue has been just the healthcare organization being perceived as having all of the resources to make all these things happen, and they don't. And so in order to make this more normalized in practice, we have to have more of an integrated system of care that, your medical providers have systems that talk to your social providers. I think when we do that, we'll start to see more and more resources come into that. The other piece is who's paying for this, right? Who's paying for it? Like I think about Food and Friends here in DC. Food and Friends delivers medically tailored meals to people who have chronic disease conditions who are homebound. These are medically tailored meals. Guess who covers the expenses Food and Friends incurs in order to do this work? Who pays for it? Well, historically, it has been philanthropy, grants, right? But we know that food is medicine. Why don't we treat food as medicine in this society? But it's easier just to write a prescription. Why? Because people get paid. People get paid off of the sick. That is why sick care works really well when it comes to capitalism, right? And so we need more and more providers to represent to see Food and Friends as a key player in the healthcare sector and reimburse or cover food for patients who demonstrate need. And that's what healthcare is all about. So when we have more of that, Jackson, when we have payer streams available to make sure that these social these community-based organizations that have demonstrated efficacy in preventing readmissions and lowering healthcare costs, when we start to see more of that, we'll see this more normalized. And that's what we're doing at the School of Health through our health economists. They're looking at these practices and putting a dollar amount on cost savings and quality of life, so that we can have revenue streams available to support these social community-based organizations.
All right.
Abrielle, I see it. Abrielle, I'm sorry if I'm mispronouncing your name.
No, you're pronouncing it correctly. Thank you so much for your talk today, Dr. King. I was wondering if you could talk more about the importance of the history discipline in public health advocacy and how you might envision historians and folks in the discipline working with public health officials.
I love this question. Embedded in my slide deck is an article that we wrote a few years, well, last year actually, and it was on atonement and the critical role of atonement in our efforts to build trust. COVID was a reminder. I mean, I knew those of us who do this work on a regular basis, we knew about this chasm, this trust chasm or distrust that we see between communities and healthcare systems and research. COVID amplified that, right? And people wonder, like, why does that exist? I think social media plays a role, but let's take out social media. Even before social media, there was this distrust that exists, particularly in communities of color, communities that have been historically marginalized and underserved, right? If we want to fix that, it is important for us, again, to critique how we do our work with an equity lens, and two, to remove those, either think about, I mentioned case studies, it could be physical statues or, remnants of our history that remind people of the pain and hurt that populations experience. When we do more of that, we will start to see, I believe, we'll start to see folks have a better perception of our healthcare sector, as well as our research efforts, right? So when we do research, we're going into communities, and for so long we would go into a community, we'd ask them to complete a survey, or we want something from that community, and then we leave, right? Not good. Not good. And so when I am assembling a team of folks, I always challenge my team. I was like, before we go into this community, what are we giving in return? Right? And so for us, it's like, when we finish this investigation, we are going to make sure that you have a copy of what we learned. We want persons who participated in our study to know what the outcome was. And even if there was no significant outcome from the intervention, that's still new knowledge, right? Something we didn't work. And it needs to be shared with the world so no one else spends time and resources doing it again, right? And so atonement is key. Reflecting on our history is key. I am an advocate, and I've been pushing this at the School of Health, that all of our students have a history lesson. And it's not intended to put a group of people down. It's just history. We believe that when people know the history, they are empowered in ways that they wouldn't be. Right? And so there's an image here of, does the name Anarcha, Betsy, and Lucy ring a bell to anyone? I want to give you one example of what I mean by the history. This here is Dr. James Merriam Sims. known as the father of gynecology, right, in the medical literature, right? And he's celebrated and held as a hero. And there's a statue erected of him in the early 1900s. This is in Central Park. Again, held in the literature as a hero. But what the story that has not been told, even though we're seeing more and more of this as a result of a lot of, public, awareness of our history and how our history has caused harm. People don't know the story of Anarcha, Betsy, and Lucy, all right? And these were enslaved women that James Merriam Sims exposed. He exposed them to very painful experimental procedures in his quest to understand how to clinically treat vaginal fistulas, right? So Anarcha, Betsy, and Lucy, their stories were not told in history, but Dr. Sims has been recognized as the father and the hero of gynecology, right? So this is an example, Abrielle, of atonement. It's removing or making sure that when we have statues like this, that people know the real deal, right? This statue was removed about 10 years ago, so it's no longer there. But what do you do with James Merriam Sims in history? I still think the story needs to be told. It just needs to be appropriately contextualized because this is our history, right? And so that's just one example of atonement. Even here at the university, I know that there's been a few buildings that have been renamed because they were named after bad actors. That is key to racial healing in this country. That is key to building trust in the institutions that govern our country. And I think that when we see more of that, we start to heal from that history. So thank you. That was a very, very long answer to your short question.
All right. I think we have time for one more question. If someone from the general audience has any questions, and if not from the general audience, if any more students would like to hop
I just have
in.
a comment. Dr. King, I was at your health equity forum like a month ago
Oh,
or
good.
so.
The
Yeah.
one at the Washington Business Journal.
Yes.
Oh, good, good.
Yeah.
Oh, glad
And
you
I
were there.
remember you talking about Dr. Sims.
Oh,
I
yeah.
spoke with you briefly after I'm a nurse, and I had never been taught about that because there's that Sims position that we put people in for certain procedures and such. And they never taught me in nursing school the history of that. And that was just really upsetting to me because people are in these very vulnerable positions, and it's basically rooted in like racism and rape against women. And I can't believe they didn't change the name of it. And we
Yeah,
still call it that today, and
I
they don't teach
know.
anything about it. It's very
Becky, thank you. Thank you for sharing that. And you know, um, oh wow. It's it, this is why it's important to have a diverse faculty teaching students. This is why it's important to have a diverse student body. We cannot tout ourselves as a world-class institution with a homogenous population. It's a disservice to our students, right? And even coming here, you know, those stories weren't told. There are a few others that would tell the story of Anarcha, Betsy, and Lucy, but if you're not part of a community that's been impacted, it'll go over. You just miss it. You miss it. But like historically Black colleges and universities, this is taught, right? And it is important for our students to have access to that information as well.
I have to
Once it's
say that
taught,
this has actually, though, been taught in women's health history for at least 50 years. So Barbara Ehrenreich's, which is midwives and I can't remember what the third part of the stories, but this is that independent women's health organizations and women's health historians have been talking about this as well. So also a marginalized community, but Just wanted to
Yeah.
say that.
Thanks for sharing that. And so you see it being brought up in different pockets, but it has not been normalized in how we actually teach. And so just knowing our history is key, I believe, in improving trust and you know, engaging populations in more impactful ways.
Great. Well, thank you again, Dr. King. It was a pleasure to have you here with us. Did anybody else have any last
I saw
minute?
one. Looks like Sylvia has her hand up.
So she's giving you a round of applause.
Oh, thank you, Sylvia. Thank you
Yeah.
so much. Thank you. So
Yeah.
can I just close out with my closing statement? Again, I want to pick up where I started and just again thank you for our time together. And I'm hoping that something will stick with you, that will challenge you, that will help you in your commitment to improving health and well-being locally, nationally, or globally. Um, you know, we have our work cut out for us. It's very clear. I hope that you don't lose hope. Instead, I'm hoping that this just reminds you that you are in the right place and doing the right thing. There's no more evidence than what we're seeing right now. You are here for a reason. We're here to do work that's bigger than us, and we're here to leave the world better off than it was when we arrived. And so I am honored to be your partner in this movement. And please be sure to reach out to me if there's any way I can help you as you grow in mind, body, and spirit. So thank you for your time.
Christopher, thanks again for participating today. It's been a very thought-provoking talk and one that I hope we can look back upon as we go through the rest of our curriculum and incorporate these ideas that you've put forth today. So really appreciate your participation and thanks to everybody for all your questions and comments during the talk, and we'll look forward to seeing you next week.
Bye, everyone. Thank you.
Take care.